beginning, allow me to say thank you very much for the organizing committee for giving me such a wonderful opportunity to participate, so thank you. I will talk about the role of intestinal ultrasound in inflammatory bowel disease. Here are my disclosures. So during the upcoming 20 minutes, we're going to talk about the evolution and the inflammatory bowel disease care, and then I will focus about the current target, which is mucosal healing. That is very essential for cases of ulcerative colitis and Crohn's disease. And then we will focus more about the role of intestinal ultrasound in diagnosing and monitoring IBD, and at the end, the rapid-fire presentations giving you a clue about the future way of modern monitoring in IBD patients. So I guess everybody is aware, like inflammatory bowel disease is a chronic inflammation that can affect the small bowel and the colon. And we know about a lot of epidemiological trial, and the last one that has been published in 2024, that they're expecting more than 7 million people to have an IBD disease. In addition to that, we are aware also that the prevalence is increasing. Also, we have another fact that we have a new update in the goal of managing our IBD patients. So we're no more hitting that symptomatic control as a target. However, we want to keep the patients away from hospitalizations and away from surgical interventions. And in order to reach this, we need mucosal healing, and there is a lot of talk about transmural healing and histological healing. And the idea is if we're able to reach a complete disease control or to change the disease behavior. We're at the end, I would say, of 2025. So these are the monitoring modalities that are available, and I've been asked to talk about intestinal ultrasound. So all what you need about intestinal ultrasound is yourself, the patients, the machine, and 2 probes, one with high frequency and the other one with low frequency. And then you would have asked yourself, like, why do we have to go beyond the mucosal healing? The majority of us, or I would have said all of us, are gastroenterologists. We love to scope our patients. Simply because endoscopy is a very invasive procedure, not very well liked by the patient because it needs a lot of preparations. We have, despite it's very low, we have a risk of perforation that is there. No one of the pregnants lately will accept to do a colonoscopy, and even some small cohort of the pediatric population. However, the advantage of the intestinal ultrasound is that it's non-invasive, radiation-free, cost-effective, and it's very reliable tool. And this has been confirmed by the recent meta-analysis when they were investigating the accuracy of the intestinal ultrasound in a comparison to our current gold standard, which is the endoscopy. And they found up to 20 studies, and despite the heterogeneity, that the pool sensitivity is hitting 89% and the specificity 86%. And then what about combining the transmural with the endoscopy? So this is a first study that has been published using the MRI as a transmural investigator tool. They included around 214 patients of Crohn's disease. They were doing perfectly well with biological therapy. And then they were checking the transmural healing. They followed those patients for 12 months. They found, as you can see here from the charts, that the need for surgical intervention, the need for hospitalization, therapy escalations, and a better outcome was within both the transmural and the endoscopic healing. But this is not only for the MRE, however, even for us as a gastroenterologist who are using the intestinal ultrasound, these prospective trials, they included around 218 Crohn's disease patients. They were taking anti-TNF medications. They were in a complete endoscopic remission. They followed those patients for 2 years. And again, from the chart and the statistics, you can see the need for dose changing and escalations, hospitalization, and the need for surgical intervention was way better when we combine mucosal healing with the transmural healing. So comparing the cross-sectional images, the CT, the MRI, and the intestinal ultrasound, we have this prospective trials from UK. They included around 233 patients, and they were comparing the IOS with the MRE, and they found that the sensitivity of the intestinal ultrasound in allocating the disease, knowing the extent of the disease in both small bowel and mainly the terminal ileum and the colon, was statistically significant with a high sensitivity and specificity. We have a certain parameters that we look for when we use the intestinal ultrasound. So the most important was the bowel wall thickening, and then also we check the color Doppler. We check the bowel wall stratifications pattern, and when it comes to the small bowel, we check the bowel motility, we check the hostrations and ulcerative colitis, and then we go extramural, checking the mesenteric lymph nodes and the inflammatory fats. And here you can see, like for us as a gastroenterologist, we cannot find the 5 layers. However, we can assess the 3 layers of the bowel, the mucosa, the submucosa, and the muscular submucosa. In a normal patient, the bowel wall thickening is less than 3 millimeter, and the stratification is a black, white, and black shade, and that's indicated that the patient is doing perfectly well. However, once we have an inflammation, you can see genuinely that we have a thickness of every single layer. In addition to that, sometimes the stratification will get disturbed. So the bowel wall thickening, our target is to hit less than 3 millimeter. And when it comes to Crohn's ulcerative colitis, also like 2.8 to 3 millimeter, except for the rectum and sometimes the sigmoid, we accept 4 millimeter. A lot of meta-analysis showed that the pool sensitivity of this bowel wall thickening can be very accurate, up to 87%. We categorize it according to the bowel wall thickening, and also we can check the vascularity. And in the vascularity, we use the Lundberg scoring, the modified Lundberg score, to see how severe is the disease inflammation. And this is an example of a... Okay, and this is an example... So this is an example of the terminal ileum. It's a thickened terminal ileum with elements of loss of stratification. We check the inflammatory fats around it for one real patient. And also we check the vascularity in the lower image. The video is not working. No, let's start. Okay. So in the lower image, we can see some sort of vascularizations. And with this vascularizations, when we categorize it using the modified Lundberg score, this is a Lundberg score of 2. That gave us a clue that the patient is having a disease activity, and it's a moderate disease activity, simply just by using the intestinal ultrasound. Also, IUS can detect the complications. No one likes to push the patient for surgical intervention, and no one likes the patients to develop complications. IUS can identify the stricture, sometimes can categorize if it's inflammatory or fibrostenotic, the fistula, maybe the abdominal fistula, and also inflammatory mass abscesses and phlegm. And we have a criteria for every single complication that the patient may develop. This is a meta-analysis including 16 trials. We're checking the accuracy of the IUS in detecting the complications in IBD. And as you can see here, that identifying the strictures, the inflammatory masses, and the fistula carries a good sensitivity and specificity if we compare it with the other imaging modalities and our gold standard, which is the endoscopy. This is a real patient. This is a 3 bowel loops connected together. She is a 30 years old lady, came to the clinic with recurrent abdominal pain. She was admitted to the surgical side, again with recurrent bowel obstruction that opens by its own. Next door, I pushed her to do the IOS for her, and I found that 3 loops were connected together with hypoechoic lesions and some air artifacts. So I told her, well, I think you have a fistula in your abdomen. And then we sent her for the MRI, and you can see it's almost 3 bowel loops connected together, pre and post contrast. This lady went for surgical resection. She had a surgical resection 3 months after, presented to the clinic. She said, I'm doing perfectly well, I have no problem. So I told her, then let's proceed with the ultrasound. And this is her ultrasound. I found that, this one. So I found that she has an element of bowel wall thickening at the anastomotic site, and she had some sort of disease activity. And that indicated that the patient is having an element of early recurrence. And because of this, we did an early colonoscopy for her, and this is the finding, which is almost compatible with the finding. So we introduced biological agents for her. And that confirms that even like post-operative recurrence can be detected using the intestinal ultrasound. So in this prospective trials, they include, in this meta-analysis, they included a lot of studies looking at the post-operative recurrence. And as you can see, again, the most important parameters, which is 3 millimeter of bowel wall thickening. Once we exceed it, then the sensitivity can be very high in detecting the recurrence. And even the bowel wall thickening of 5 millimeter and above can carry a really good sensitivity and specificity in identifying the disease complications. So we can know if it's like an early mild, early moderate, or early severe just by measuring the bowel wall thickening. Yesterday, our great Pakistani doctors, they were asking me about the perianal fistula. And I guess we hate perianal fistula when it comes to Crohn's disease. And then they asked me, like, will the intestinal ultrasounds be able to detect such a complications? My answer was yes, but if we go with perianal abdominal ultrasound, perianal ultrasound. So with the perianal ultrasound from this Japanese systematic review, they found that 25 studies they were looking for this. And the total cohort of number of more than 1,400, they found that the poor sensitivity, specificity, and accuracy in detecting fistula and fistula collections, and also the colonic and intracolonic collections, and the anal detection, anal fistula detection was very high and very accurate, as you can see here from the study. Also, other complications that we don't like if we just move to the colonoscopy, so the ulcerative colitis. When it comes to ulcerative colitis, we don't like our patients to develop severe complications, especially when it comes to acute severe UC. We hate sending our patients to a total colectomy. So this is prospective trials that has been done for Netherlands. They were scanning the patient in 3 months interval. They started with the baseline, they started with the medications, and when they assessed the patient 3 months after, they found if the bowel wall thickening of 3 millimeter by 3 months, it carries almost zero. If you can see here from the chart, it carries almost zero risk of pushing the patient for the OR operation theater. However, if the bowel wall thickening of 4 millimeter and above can increase the risk of colectomy with a high odds ratio of 1.5 and also shorten the time until the patient go for the operation theater. This is a case of a patient who came very bad abdominal pain, bleeding per rectum, diarrhea, weight loss, night sweat, and he's a long case of ulcerative colitis. So we thought that he may have like an acute severe UC. So this is the scope. That's not moving. Sorry. This one. So you can see here we have a 3 thickened bowel wall, and we have transmural thickening. We have stagnations of the fluid inside, surrounding inflammatory, lots of surrounding inflammatory fats. You can just check. This is the sigmoid colon. We know that the flexible sigmoidoscopy, for in a case of acute severe UC, we cannot advance and do a total colectomy. So we did the, I think the next second video is not working. Can we just go second video? Okay. So this is the transverse colon. So I advanced with my scan. So this is the transverse colon, which is also thickened, inflammatory fat, and lots of fluid stagnations and dilated colon. And this was also applicable for the ascending colon and the cecum. So I told them for sure this patient is having an element of pancreatitis and he's like in a bad shape. The corresponding colonoscopy, the corresponding flexible sigmoidoscopy was almost the same. And then the question was, shall we send the patients to the operation theater or just consider rescue therapy? To answer these questions, this is a single study that has been done again from our colleague in Netherlands. They included 56 patients, and the majority of them they went for presented with acute severe UC. At the baseline, as you can see here from the chart, they were almost equivalent. However, after 48 hours of introducing steroids, we were trying to allocate who were responsive. And then within time, they found if we have a reduction within 48 hours of applying a steroid, the patient can go for rescue therapy. However, if there is no response, then the gentleman will need a total colectomy. We like to have scores. We have Mayo score, we have SES, Crohn's disease score, so we have a lot of scores. And even with ILS, we do have scores. So we have the IBIS-SAS score that has been done by Kerry Novak. She included some certain parameters to identify the disease activity and severity, especially when it comes to Crohn's disease. In the case of ulcerative colitis, Mariangela Aloga, she has a Milan ulcerative colitis score, and it's really accurate to score in knowing the disease activity in UC. Even the US team, and mainly Mike Dollinger, he was having a validated score for the pediatric cohort, and the majority of these scores and one meta-analysis showed that the accuracy rate is really high. We love to include our patients in the management. We love to ask them what do they want and what do they need. So when we, in this national survey that has been done in the Scandinavian country, they sent a survey for more than 900 patients, and you can see in both the Crohn's disease and the ulcerative colitis, both they like to go for the non-invasive tool, and ulcerative colitis is one of the topics highlighted. Specific population, which is a pregnancy. We get stuck when we have a pregnant lady. She comes to us, we don't know if she's like an IBS, is it because of her big belly, or we have some sort of disease activity. So they like it because it's safe, as I said, radiation free. However, when we can monitor the bowel wall thickening up to 28 weeks. And you can see it here that the sensitivity at the first trimester and the second trimester and the specificity is really high, and we can identify the disease extent and the disease location. However, it drops when it goes to the rectum, either because of the big belly and because the rectum is really hard to be allocated. Pediatric patient is another cohort. No one likes to scope the patient twice a year or 3 times a year. So with our validated score that has been done by Mike Dollinger, the sensitivity and the accuracy of identifying disease activity, especially in these cases, are very high. And also they were having like a sub-score, as you can see. Like if they do scan for the patient in week 8 and they found a reductions of the bowel wall thickening of 18%, that means the endoscopy will be almost normal and the patient in a complete remission. And as we move on till like 1 year, a reduction, normalizations of the bowel wall thickening of more than 50%, that means the patient is doing well and it correlates nicely with the endoscopy. We scope our patients when it comes to Crohn's disease in 6 months to 1 year by max, and we scope our ulcerative colitis like a bit earlier. However, you can use intestinal ultrasound way earlier in monitoring your IBD patients. So this is a sub-study from the Stardust done by Torsten. He was applying the definitions of the endoscopic remissions and IUS remissions and IUS response, and he found that the patient will be able to respond to the treatments after 4 weeks, and then it was applicable in both the small bowel and even the colon, and the normalization at times goes on, and this was statistically significant. And even in ulcerative colitis is the same. So the TRUST and the TRUST UC showed that the response and the normalizations of the bowel wall thickening of the treatments and the vascularizations can go down after 2 weeks of introducing the treatment. So you don't have to stop, you just monitor your patient on a regular basis. So to wrap up everything, most of the recommendations, and including the ECOISGR IBIS guidelines that has been published 3 weeks back, we know our intermediate target is to keep the patients in remission, especially biochemical remissions. However, you can use intestinal ultrasound at the time of the diagnosis and 12 weeks after the treatment of ulcerative colitis and Crohn's disease, and then in 3 months interval. And even you can scan the patient if you want to escalate, de-escalate, or change your medications freely without any problem, just using the intestinal ultrasound in a correlation with the biomarker. Also, nowadays the guidelines are incorporating IUS usage in monitoring our IBD patients. So you can see the updated ACG guidelines that we're talking about IUS, the AGA, the ECOISGR guidelines, and also the British guidelines. Is it cost effective? Again, I was asked by our colleagues from Pakistan, is it like cost effective? The answer is yes, cost effective, because the IUS can stretch the interval of the endoscopy and the MRI, so you don't have to do it very frequent. And that can cut the cost 30 to 50%, Dr. Lubna. And also you can see if you take the patient in a journey of 1 year, when you use IUS, the cost is like 15,000 K in comparison to 25 K with the endoscopy. A meta-analysis showed that the pool cost reduction using the IUS in comparison to the MRE and the endoscopy can hit 35%. So I believe it's a cost effective. We have limitation like any other procedure. So we can identify the colon, the terminal ileum, and the disease. However, when it comes the sensitivity can drop. So that's why the full sensitivity can drop up to 68% because it lies deep in the pelvis. And for the ulcerative colitis, because the target is the histological healing, and up until now is not like the transmural healing, so we need a lot of validation score to integrate all these things together. So IUS is an non-invasive and it's radiation-free. It can be done in the clinic as a point of care. It's a very accurate, comparable with the other cross-sectional images and with the colonoscopy. It is an expensive tool in comparison to the endoscopy and the MRI, and also it can give you a clue about the mucosal healing, and also it has a favorable long-term outcome once you visualize the transmural. The future is hiding a lot of non-invasive monitoring. So what about, instead of having a bronchodilators, we have a smaller spacer, the patient to blow on it, and then from this component we can detect if the patient is having any elements of disease activity. Possibly in the future, we're not sure. Other thing, we use more modalities with our intestinal ultrasound, in which sometimes we inject a contrast. Injecting a contrast can detect the complications, can differentiate between phlegmon and abscess, can differentiate between a fibrostenotic or an inflammatory stricture. In addition to that, we're at the era of technology, so instead of having application to play games, so we can use it by wearable applications, including the smartwatch or the iPhone, to monitor the heart rate, the physical activity of the patient, the number the patient goes to the washroom, and in order to detect an early recurrence and ask the patients to come to the hospital. Artificial intelligence, we use it a lot. Some people are like chatting with AI. However, using the AI in collaborations with the endoscopy can give us a good analysis, because the accuracy of using the AI in giving you the score and the inflammation is really high and can increase it by more than 15% of our regular ones. Pharmacogenomic TDM, which I hope that we can reach this point, in which by checking the pharmacogenomic of the patient, you can know which medication is the best for this patient, instead of changing and checking the regular levels of our patients. And the last, and instead of just using simple glucometer by simple pinprick, we can check the drug level of the patient. And this was done for the vedolizumab patients, and they found if the patient is having an early recurrence or if the level of their medication is suboptimal. So just to conclude, IUS is a very accurate tool, and it's repeatable, non-invasive, radiation-free, can detect IBD activity with the complication, real-world assessments. You can get the answer right and instantly and identify the complications. A lot of guidelines, the STRIDE-2 trials, are encouraging us not to follow a control of the symptoms themselves. However, we can go with a lot of non-invasive monitoring, including the IUS. I believe personally that IUS can transfer your IBD care, and it's cost-effective and I consider it as one of the patient preference. The future may hide a lot of non-invasive monitoring for IBD, so we can use it, but it's a matter of time. So, if you are interested in intestinal ultrasound, kindly join us in IBIS. We are a non-profit organization. We aim to educate people and to do some researches in correlation with the IUS and the IBD. So you can see all of us are there, international doctors from different countries. Join us, join the curriculum, and be an expert in doing intestinal ultrasound. Thank you very much.
Thank you, Hiba, for a fantastic overview about intestinal ultrasound in IBD patients. We will open the floor for questions. I'm sure there will be fantastic questions from the audience if you have any questions. I will start. The first thing, as you mentioned, it's mostly for the follow-up the cases, not for diagnosis new cases.
No, actually we can use it as a baseline. Like yesterday at the workshop, I showed my colleagues that if the patient is coming like with IBD versus IBS, because we're sharing the same symptoms, especially when it comes to abdominal pain, bloating, and weight loss with the diarrhea. So you can scan the patient as a baseline and then stretch it, so you don't have to rush to do the colonoscopy. So once we have a normalization of the bowel wall thickening without any problem, that means the patient doesn't have an IBD. So we can use it as a diagnosis and during monitoring.
And talking about the learning curve for those who never used abdominal ultrasound, even for just scanning abdomen before intestinal ultrasound. So can you tell us the clue how to make it fast learning up, or how frequent we have to do it so we can be mastering that?
Sure. So again, I told my colleague yesterday, so the learning curve is not that difficult and it's not that easy. So all what you need is just to follow a certain curriculum. So with IBIS, we have 3 days like introductory workshop upon how to use the machine, how to be familiar with the machine for 3 days only. And then you will have to scan in an accredited center under supervision for, I would say, 2 weeks or a month, just to do a total of 40 cases. And after that, you will go for the exam in a collaborations with ECHO, and then you will shoot. Again, Dr. Udna asked me about like when I'm going to be confident after completing the curriculum. I would have said that if you're able to do 50 scans after completing the courses, you will be confident enough to scan the patients.
Okay.
Thank you very much for your excellent presentation and detailed presentation. I know it's not this session's subject, but I wonder if there are some clues from ultrasonography to differentiate for differential diagnosis of IBD from other bowel disease. For instance, for tuberculosis and Crohn's disease, we have some clues from tomography. Are there any clues for ultrasonography to differentiate from other bowel disease? Thank you.
Thank you very much for this question. I think this question is very interesting, very important. Actually, to differentiate between the infection and the IBD is quite challenging, to be honest. And we don't have like much studies, like 3 prospective trials. They were trying to investigate this, but the answer is still like an area to be considered to know about what's going on. However, we say that if you have a terminal ileal due to the TB, you won't have like the skip lesion pattern. You won't have the transmural inflammations. You will have more lymph nodes and less inflammatory fats in comparison to the IBD. But is it like the clear cut, or is it like a confirmatory? No, I wouldn't say a confirmatory. So differentiating IBD with the mimickers is quite an area of challenge. Thank you.
Excuse me, you told us about the cut point of 3 millimeter for the diagnosis between the normal and abnormal. The cutoff point can be varied geographically between the Western country and Eastern country and other conditions that I don't know about this. Is it the fixed limit?
Yes, thank you for this question. Actually, the bowel wall is the bowel wall, so it's not a big difference between the Western and the Eastern countries. In addition to that, even in the most of the prospective trials, it has been done worldwide, and it was including different ethnic origin. So that's why the 3 millimeter is applicable for the whole world, not like certain people, the Western or the European countries.
Thank you very much for your presentation. Obese patient is a very big problem in intestinal ultrasonography. I want to learn your practice in obese patient in inflammatory bowel disease. Obese.
Yeah. Obesity is a challenge for every single person who uses intestinal ultrasound, but and even ultrasound in general. However, we do always say just try it. You'll be surprised. Like sometimes you'll be like very much obese, but you can identify the colon. But sometimes no. So once you won't be able to find it, then you have to go for other modalities.
Thank you very much, Hiba, for fantastic.
Second speaker is Mr. Taylan, Mr. Kav. Mr. Kav works as a gastroenterologist specialist at Hacettepe Üniversitesi. My college is interested in inflammatory bowel disease, especially treatments.